because these patients, they can live longer, they can feel better, and their left ventricular function will improve. So the evidence supported the surgeons to do aortic valve replacement for patients with severe aortic stenosis. But unfortunately, this is not the real life. In 30% at least of these patients, they are treated conservatively in the general practitioner medication treatment. They are not well treated. Why? Because these patients, they are comorbid, they are elderly, they have a lot of comorbidities, and usually the elder population, they refuse to have any surgical intervention. No one of us like to go for the surgery. It's something more or less, it's not our preference. What is the startup? When Alan Crebier, he was a grave man, and also with a grave patient, was dying patient with extensive peripheral vascular disease, has a severe aortic disease, and this patient has a liver problem, and he was not expecting to have a good survival. Then he agreed to volunteer to have the first in man transseptal across the left ventricle and aortic valve replacement as a first in man. This is the spark that gave everyone that there is something called TAVI or percutaneous aortic valve implantation. But what the community say, this crazy project will fail. What they are doing, they will have strokes, they will have an aortic rupture, they will have coronary occlusion, mitral valve injury, this valve will embolize, will have a lot of paravalvular leak, a lot of vascular complication, the valve will not last for long, blah, 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 blah. So, this is what happened. But what about the reality? The severe AS population, this is the type of patients. They usually, when they started, they are old, very old, frail, prior CABG, chronic kidney disease, severe COPD, peripheral vascular disease, chronic atrial fibrillation. Some of them passed to previous cancer therapy, but they are still enjoying their life. What we can do we have to leave them alone? So we characterized a high-risk patients or the surgically prohibited population that raised the concept of heart team and multimodality imaging, and the technology started to develop to create a valve that can be easily to be implanted percutaneously, and started the clinical research to see is these percutaneous valves, they are similar or non-inferior to the surgical valves. Over the last decade, TAVR has developed from a niche procedure to an integral part of the treatment algorithm of aortic stenosis. Because the TAVR is now the preferred therapy for a group of population of patients. Number one, surgically prohibited patients. Number two, patients with ultra high risk or very high risk surgery or high risk surgery. And some patients of the intermediate risk groups. And now the people, they are looking to the low risk group. But look carefully to this graph. If we look to 2012, when the partner trial data started to happen, there was around less than 5,000 implants of the TAVR, and the surgical valve implantation, it was around 30,000. After 6-7 years, the number of aortic valve replacement surgically is almost the same. And the number of patients with aortic valve replacement plus CABG are a little bit increasing. But while as the TAVI is around 5 to 6 folds at least increased, it is almost 10 folds increased from 2012 to 2018. So it means that there is a more number of patients without affecting the number of the surgery, because they are taking the untreated population or the people who was left alone with the medical treatment to their destiny. The TAVR, the ongoing trial in low risk population, which we have a lot of reservation for this one, will address the potential expansion rule of the TAVR, and also to provide an important data about one point, which is the cornerstone, which is the durability. The TAVR has forced the guidelines to change, but it's only the startup. This is still a long road. We need a rigorous clinical evaluation and clinical trials. The 7 randomized clinical trials try to compare the outcome, the very meticulous outcome of the surgery against the surgery as a gold standard versus the percutaneously implanted valves. These multiple trials, not only these 7 other trials for other valves, the trial designed to show equivalence or non-inferiority to surgery, but what about superiority? Yes, there is a great group of patients, there was a superiority to the surgery. What was the end point to be considered? If we look carefully to the Partners trial, which is the cornerstone, there is a significant decrease or superiority of the mortality as an outcome. And also, when it is compared head to head, it is. The enrollment started in 2007 with a very large sheath and 100 patients. The first generation sheath was 24 French, which is, it's massively large for the peripheral vascular. But actually, this was the patients. But the real data of the Partners trial, this is not expressed by this one. But when the technology changed, the valve changed from 24 French nowadays to 14 French. The maximal or the larger number of complications was happened and mortality within the first 30 days was related mainly to vascular complication, was not related mainly to the valve. It was very little related to the valve. But when the technology could crimp the valve and allows us for a smaller delivery system, it gave us much improvement in the vascular complication or the vascular access. If we look in details to the other way, what about the intermediate? Already we swallowed the surgically prohibited population and the high risk population. What about the intermediate risk? The intermediate risk does not mean the younger population. The intermediate risk patients above 70 or 75 years of age, he is morbidity free. This patient only, he has a severe AS, very mobile, ambulated, active, he has no cerebral problem, no other comorbidities at any. Some of them, they are in the intermediate group. What about the outcome? When we compare the 30 days and 1 year, it is much better with the TAVI. What about the disabling stroke? It is superior for the percutaneous access, for the percutaneous implantation. What is the mortality benefit? When it starts, if we look carefully to the graph, it starts from the early days, from 3-4 days, you have a significant separation of the curves of the, in favor of the percutaneous valve implantation. What about the stroke risk? It is much lower stroke risk, at least 2.5 to 3 times more for the surgery. What about the complication rate? As major bleeding, vascular bleeding, paravalvular leak, hospital stay, aortic atrial fibrillation, all in favor with the percutaneous. What about the easy recovery, the hospital stay, absence of any scar, any wound? This is in favor. But the people, they do not mention some of the drawbacks of the percutaneous, which is paravalvular leak, heart block, and early they denied that these 2 factors or 2 complications are not related to mortality, but this is not true. It is proved that significant aortic regurg and heart block and even left bundle branch block all are related to long-term mortality outcome. So, what about the other valve? The Medtronic valve also, it could give itself a non-inferiority but not superiority for the percutaneous valve in the intermediate risk group with the SURE-TAVI group. After this bunch of trials with very alarming or very clear difference between the surgery and the percutaneous option, does the guidelines change? It is cautiously changed. That what happened for the guideline? The guidelines said For patients with prohibited surgical risk, there is no discussion. These patients, they are going for TAVR. What about the patient for higher risk group? If we look carefully to our community, we have a lot of patients, they cannot pay, and we have pioneer surgeons, and we have a good outcome, we have a good intensive care. Still, surgical aortic valve replacement in high risk patients can be done. What about the intermediate risk? It's the same. If we have facility, if we have good intervention cardiologists, they can manage, and we have social or economy can support that. Yes, intermediate risk can be, but still surgery is class 1 indication and the percutaneous is 2A. Yes, it is valuable, it is beneficial, it can be done, but it still did not replace the aortic valve replacement. What about low risk? Till now, which is very clear in the guidelines, low risk patients, they are not class 1 or 2A even. Still, low risk patient, they should go for the surgery. What about the data of the low risk? It came in the 2018 and early 2019. Again, it is very evident that the percutaneous option, the percutaneous valve replacement is far away superior to the surgery as regard mortality, as regard morbidity, hospitalization. This came for the balloon expandable valve. It's almost the same, and it came later on for the self-expandable valve. But if we look carefully to this graph, when we compare the surgery to the paravalvular, to the percutaneous option as regarded the paravalvular leak, there is less than 1% for both groups. They might have a significant or severe aortic regurgitation, but the surgery is completely superior to the percutaneous as regarded the paravalvular leak. But if we compare in real digits, we have the major bleeding, the major vascular complication, acute kidney injury, new left bundle branch block. When we compare, the superiority for the TAVR was in the major bleed, was in the mortality, but in the left bundle branch block, it is 4 in favor for the surgery, and the pacemaker rate was also in favor for the surgery. For this trial, it was not superior to surgery, but for the self-expandable, the surgery was more superior. And this is the other trial, which is for the core valve, comparing TAVR versus surgery in a low-risk patient using the self-expandable valve. It proved itself also that it is superior to surgery, which is also again very alarming, that all the patient population who are going to the percutaneous option, they have a better outcome compared to surgery. But what about the valve performance itself? If the surgically implanted valve is better than the percutaneously implanted valve, unfortunately no. The percutaneously implanted valve is proved to be superior to the surgical valve, that this valve has a better effective orifice area and much less gradient across the aortic valve. This is not enough. What about the longevity of these leaflets? We are going to address it in a second. So we have an evidence for the TAVR for both available valves. Why? They have a lower stroke rate, they have a lower mortality, they have less atrial fibrillation, they have a quicker recovery, they have better hemodynamics performance of the valve, and they don't have scar. But we have here in the vascular media, we have a major problem with the vascular access. How to select our patients? We are going to percutaneous option or to have an open. There is pros and cons here. If we have a surgical cut down, there is a good exposure. Experienced surgeon, I saw them, they do it faster than what we do with the ProGlide. They have a tactile feeling of the calcium. They can select properly the proper spot. And also they have a definite repair of the arteriotomy without any later on problem. But we don't have a tissue tract to support the sheath and the aggressive maneuver of the cardiologist during the implantation of the valve. still there is a risk of infection, there is a wound, probably we have a longer hospital stay. What about the percutaneous option? It's tissue track supporting the sheath. We don't have an incision. It's supposed to be faster, but you do not see the puncture site and the complication is still there. But remember, all the time, when you have a surgical exposure, it does not protect you from having a non-access or non-exposed site of the vessel. Sometimes if we are not selecting the patient properly, we might have an injury away from the field, and this if we are not able to bail out the patient, we will lose him, and there will not be enough time to salvage this patient if you have a major rupture of the vessel at the site of the distal aorta, common iliac, or high in the external iliac, because they lose a lot of blood in no time and they can crash in no time. We have other axes. For the TAVI, they started with the apical axis with the transfemoral, but nowadays we have axillary, we have subclavian, we have carotid, we have femoral, we have direct aortic, we have transcaval axis, and all these axes are available for the TAVI to bypass the severely diseased peripheral vasculature. And for these vessels, when we had the large vessel, we used the percutaneous closure. Either it is suture based to have a percutaneous as ProGlide or ProStar in the past, or we have an adhesive plug similar to the Manta coming in these days, or we can go from the ipsilateral or contralateral limb to put a covered stent to bail out if we have a problem. For the transcaval axis, we can cross from the inferior vena cava to the abdominal aorta. We can cross the sheath. We can go up doing the TAVI, and by the end we put a closure device to bail out this. And the international data, they have less than 3 to 4% mortality. They have less than 5% morbidity or a complication rate. But above all, if you compare it to the what we call prohibited vascular access or an extremely difficult vascular access, still the outcome is much superior than other axes. So in these days, what we have to do for our patient, to send them for surgery, for surgical aortic valve, or to do a percutaneous option. So we have to address or to answer some question. What about the durability? The surgeons, their data is more or less confusing. The surgeon say that when you implant the valve in a patient beyond than 70 years, you expect more than 15 years of the durability. But in real life, it does not happen, because the surgeon, when they counted from the day of surgery till the day of the second surgery. But when nowadays, in the media of TAVI, we compare more meticulously. We compare when the valve start to have a structural degeneration, when you have a significant increase in the gradient or significant decrease in the orifice area or a new appearance of aortic incompetence, and they compare head to head. So for the durability, unfortunately in the TAVI media, we had something which is very bad. What we call it's a leaflet frozen or the leaflet thrombosis. This is either it is subclinical or it is evident in clinical context. Unfortunately, or the bad luck of the Portico valve, when they presented their data, when they did a 4D, they found that 40% of their valves, they had what we call a leaflet dysfunction or a leaflet thrombosis. It was, in some of these patients, was clinically evident and some was occult. What about the major trials that the people are so proud with it, which is the partner? Actually, in the partner, they found also 7% of their patients, they have a leaflet thrombosis. And this is why the FDA raised a very, very important letter to the manufacturing company that we have to follow our patient, that we have in the partner trial, in the subgroup analysis, they found 7% of a limited group. Not all the patients had the evaluation, it's only 88%. That was 5.7% of these 7% was clinically silent, with no evidence of valve destruction, with no evidence of embolization, with no evidence of what we call symptoms. But in 1.2% of this group, it can be symptomatic. So another point raised, what would be the risk factor for this? Either to use a warfarin, at the surgeon that was using warfarin, or no warfarin. It was also noticed for a 29 valves. Is any risk for this one? Yes, there is what we call theories why this can happen. The lack of normal diastolic flow or the geometry of the sinuses, which is now blocked by the big lump of calcified leaflets in the sinuses, so the diastolic flow in the sinuses are impaired. So we might have stasis, and also asymmetrical or incomplete valve deployment, or what we call a full valve symmetrical implantation, does not allow a free, uniform, symmetrical leaflet mobility that it can lead to stent leaflet thrombosis. And also, some of these patients, they have a lower cardiac output, either due to the stroke volume, which is low because of the severely hypertrophied ventricle, or the patient, they have an impaired left ventricular function or an associated mitral valve incompetence. All this with low cardiac output increase the risk of stent thrombosis. How we should diagnose? Should everyone had a TAVI to have a 4D CT? Probably. When? For how long? It's a big question. What is the rule of anticoagulation? Is all patients had a TAVI should be anticoagulated or not? What is the clinical follow-up for how long? And what is the frequency? And how we can apply this group or this complication for the low risk group if we are talking about. This is a very important statement. Until there is a long-term, more than 10 years, reliable clinical and echo data on normal risk patient or low risk patient treated in this modern era of percutaneous option, there will always be a concern regarding to the durability of the leaflet. We should not rush to put these TAVI valves in a lower risk patients. We have to be very cautious. Does the early mortality benefit of transfemoral TAVR versus SAVR mitigate some of the durability concern? This is a big question. I'm saving the patient in acute results or an acute outcome. If this one is enough to turn the surgery away and to go through this percutaneous option, the ability to do valve in valve helped some, because if I have a patient, he had a TAVR and then he had a dysfunction of the valve. Nowadays we have valve in valve or valve in TAVI, TAVI in TAVI, it can solve the problem, but I don't think it's enough. The ongoing research should give us the answer why and which risk group we have to be very cautious. Similar to the surgical SAVR, there will be some patients with failure, but it is incidence. There is some patients had a surgical aortic valve implantation and they are presented in less than 5 years, in less than 5 years with a degeneration of the valve. But how much percent? You have to compare head to head the TAVR valves versus the surgical valves. If you are not non-inferior or superior, we should not consider that the percutaneous is better. When you are trying to expand to the lower risk, you have the core valve and the Medtronic, they proved themselves, and they also support the what we call the very meticulous follow-up. Another issue which is crucial, what about the coronary access after TAVR? We usually put the valve and go home. What about if this patient presented with an acute coronary syndrome? If this patient, statistically how much? If according to the meta-analysis that 40 to 50% of the patients who had TAVI, who could survive more than 5 years, they should have a coronary angiography or coronary intervention. This is not a small population. This is a big number. So when we are putting the valve, we have to know that do we have an accessibility to the coronary or not? Are we able to access the coronaries or not? When we are comparing the core valve to the Edward valve, we should know the difference. We should know which patient has a higher risk of coronary occlusion, or which patient group already they have a coronary artery disease and they are coming for a percutaneous intervention, I should select the proper valve for them. What about the new, which is, I think this is much more important. Any patient who has a surgical valve implanted and now is coming with a degenerated valve. Now this is a real evolution that we can have a valve in TAVR patient, in degenerated biprothetic valves, but still another question which is the mismatch. There is at least 15% of the patient in this population, they have a patient prothesis mismatch. If we put another valve inside, we will come out with the same mismatch. We will not have adequate hemodynamics. And improper hemodynamics is tightly related to the mortality. If I don't have a good valve function, the 1 year mortality is more than 30%, if you can say, in very severe mismatch. But for all the comers of the mismatch, they have at 10 years 30 to 35% mortality more than the non-mismatched patients. But we have something interesting, that some of these patients nowadays, in most of the percutaneous valve, we can fracture the bioprothetic valves and to implant a bigger, better functioning valves. It can give us a much better outcome for long term. What about the bicuspid valve? The bicuspid valve, what is misleading in the trials, that I have to admit, all the major trials, they exclude the bicuspid valve. They do not include the bicuspid valve in their trials to make sure that they will have a good outcome. And this is not fair. You have to, nowadays, the new studies they are doing, we have to make sure that we are getting all comers. Why the bicuspid valve are a big problem? Because they have asymmetrical or asymmetry in the valve. They have a larger annuli. They have a variable types. We have aortopathy associated. We have a very bulky leaflet, calcified leaflets. And which valve? Which valve we will implant? We will circularize, or we will take another valve. It takes the shape of the oval shape of the annulus. What valve size? According to what? The annulus to the intercommissural distance, or what? Where we anchor? What about the coronary access for this patient? So when they started to compare the TAVR patients, the bicuspid versus the tricuspid, they found that the new pacemaker was higher. The paravalvular leak was very significantly higher in the bicuspid group, but fortunately the 30 days mortality and the early safety mortality was not changed, but the device success rate was significantly lower for the bicuspid as compared to the tricuspid valve. Is the durability the same? If the devices all they will fit, what we are going to do for the aortopathic? So if we are searching for the new indication for TAVR, the surgical aortic valve replacement, they are already succeeded in symptomatic severe aortic stenosis in low-risk patient, bicuspid aortic valve, pure aortic regurgitation, concomitant aortic stenosis and coronary artery disease, concomitant aortic stenosis and other valvular disease, better treated with the surgery. But they are still struggling in asymptomatic severe aortic stenosis, in symptomatic moderate aortic stenosis, and severe AS in hemodynamically compromised problem. A new vision, a new era, a new way of thinking, which is the TAVR unload concept. What is the unload concept? This is patients with impaired left ventricular function, ejection fraction less than 50. They don't have severe AS, but they have moderate AS. What will happen if you compare two symmetrical groups? One will be for TAVR plus optimal heart failure management versus only heart failure management. Nowadays, we can think about doing this, but before I cannot send a patient with impaired function, with moderate AS to the surgery, but because the TAVR are less invasive, less peri-procedural mortality and comorbidity, better tolerability, immediate recovery, larger orifice area, all this, it can help the patient. This difference may allow the TAVR to invade this big population of patients. Which valve? We have a big number of valves coming these days, but each device interact with the aortic valve complex differently. And the ongoing issue for anyone should prove himself by the durability, coronary accessibility, commissural alignment, and how it is related to the coronary and the cost of each device. But none of these valves available could address 10 by 10. No, everyone has its own deficiency. But nowadays, again, we have another point of thinking. We have to stop for some patient. We say this group of patients should go for medical treatment. We should not even offer them TAVR. Patients with severe frailty and limited survival, patient with severe dementia, big question mark to do them or to leave them. Patient with severe liver cirrhosis and severe COPD with very limited activity, and we don't know what to do, to offer them TAVR or to leave them for medical treatment. The context of the patient's population for aortic valve replacement was almost less than 10% high risk group. It is already done by the TAVI. Around less than 15% for the intermediate risk group taken by the TAVR, but around 80% of the low risk group now is the battle or the competition. But still, the guidelines does not support low risk patient to go for TAVR, only the high risk and the intermediate risk. To look carefully to this one, never ever think that the high risk, intermediate or low is related to the age. Patients 90 or 80 above, we are all happy to serve them with the TAVI. Patients 70 years to 80, they are intermediate or low risk patients. We have to categorize these groups of patients to say which way, but we have to consider 100 times 60s which way we have to send. Still, the surgical aortic valve replacement is the standard. Going back to our patients, we presented with a severe aortic stenosis. This patient was better served with the TAVI. We offer her, we fixed the coarctation first with coarctation stenting, and then we put her the TAVR, and finally we put her the stenting to the LID. I'm following this patient because she is my patient for the last 3 years. Her valve is doing very well. The patient had no single hospital admission, and she is almost asymptomatic. In the early days, the struggle, the role of engagement was like that, but nowadays the role of engagement have been changed. Nowadays the TAVR people, they are supporting themselves to have a better outcome. My final thoughts that the TAVR has successfully addressed an important unmet clinical need for a common disease, has saved the life and improved thousands of patients who otherwise would have been left untreated with a catastrophic outcome. The TAVR has catalyzed a medical culture of dynamic, multidisciplinary physician collaboration with the framework of imaging, surgeons, intensivists, anesthesiologists, what we call the heart team or the heart valve team. Thank you very much.